Welcome to this chimpanzee's presentation on selective dorsal rhizotomy. My name's Caroline Hardacre. I'm a children's physiotherapist. I've worked with children with cerebral palsy for many years, both rehabbing in the community and more recently for Bristol Royal Hospital for Children in their SDR service. This presentation has been written for the parents and carers of children who have a diagnosis of cerebral palsy and are wondering if SDR might be right for their child. So today I'm going to talk through a few things before we actually talk about SDR, because I think it's important to consider SDR as just one spasticity treatment option, of which there are a whole toolbox available to us. So I'm going to talk about why moving can be difficult for children who have cerebral palsy, and we're going to classify spasticity and dystonia. We're also going to look at how, as physiotherapists, we assess how a child moves, and that's with the Gross Motor Function Classification Score and the Gross Motor Function Measure. Then we'll talk about treatment for spasticity in children who have cerebral palsy, before looking in much more detail at selective dorsal rhizotomy. So you'll see on your screen the different timings for the different sections of the presentation. So I'm sure as parents you're really busy, you probably don't have time to listen to the whole thing as a chunk. You feel free to skip around as you need to. So moving for children with cerebral palsy. Cerebral palsy is a neurological disorder caused by a non-progressive brain injury or malformation that occurs when the child's brain is developing. And cerebral palsy primarily affects body movement and muscle coordination. So children can have problems with their muscle tone, with spasticity, muscle weakness and strength, and also their control of movement, so how the brain sends messages down to the muscles to tell them to move at the right time and in the right way. Now, when a baby and a young child is learning to move who doesn't have cerebral palsy, typical movement development has really clever building blocks. So a baby will learn to roll, and that in turn gives them the opportunity to gain strength in their trunk, which enables them to sit. And then from sitting they move into crawling, and the movement of crawling helps build strength in their leg muscles to then go on to be able to walk. And this is really disrupted for children with cerebral palsy. I'm sure you will have noticed in your own child that progression from one skill to another can be really difficult. Now, spasticity is only one piece of that puzzle, but it is an important one. And what SDR does is it permanently removes spasticity, which provides an opportunity, together with therapy, to build strength and to help the child gain more typical patterns of posture and movement. But there is always a ceiling to someone's potential. So no matter how hard I train, there would be a limit to how fast I could run a marathon. And a big factor of that is how much training I'm willing to put in. And I think that's a very similar situation in SDR, is that a child's baseline abilities plus their motivation and compliance with therapy is really key in determining what their potential outcome may be following SDR and rehabilitation. So let's look more closely at what spasticity and dystonia are. Spasticity and dystonia actually come from damage to different areas of the brain. So spasticity arises from damage to the motor cortex, and dystonia from damage to the basal ganglia. Children with dystonia tend to have more significant difficulties with moving than those with spasticity, and so children who have a higher GMFCS level tend to be more likely to have dystonia than those with a lower level. A combination of different movement disorders is often present, and high levels of spasticity can mask the presence of dystonia. So let's define spasticity. It's called a velocity-dependent increased resistance to passive limb movement in people with upper motor neuron syndrome. I don't know about you, but that doesn't mean very much to me. So let's unpick that. So what it means is that when your child's arm or leg is being moved by you or by a therapist, that resistance can be felt. And the faster that limb is being moved, the more resistance that is felt. So if I'm trying to straighten your child's arm and I'm moving it slowly, it feels tricky, but I can do it. If I try and move it fast, there's much more resistance. That spasticity kicks in. And that's what velocity dependent means. It means the faster you're moving the limb, the more resistance there will be. Upper motor neuron syndrome means that there has been damage to the brain. So hopefully that sentence, velocity dependent increased resistance to passive limb movement in people with upper motor neuron syndrome, hopefully that makes a bit more sense now. Lots of body muscles work in pairs, so one is shortening whilst the other one is lengthening. So with the arm, biceps is shortening whilst triceps is lengthening. So the brain is sending messages to the muscles telling biceps to contract and triceps to relax. Now when you have cerebral palsy, the damage in the brain makes it difficult for those messages to be sent properly. So the circuit between the brain and the muscles is disrupted, and that's what results in spasticity. And it's often more noticeable in one of the pairs of muscles around a joint than the other. So spasticity is often more significant in biceps than it is in triceps. What is dystonia? So dystonia is sustained or repetitive muscle contractions resulting in twisting and repetitive movements or abnormal fixed postures. You might notice in your children that dystonia is worse with intention to move. So they'll be thinking about moving or trying to move, and that's when you see that dystonia can kick in. So it can be an overflow of movement into an area of the body that isn't necessary. So they're trying to do something and part of them is moving and you think, well, they don't need to be moving in that way to do what they're trying to do. So they might be sitting unsupported and talking to you, and you notice that their arms are coming up or that their toes are curling up, and that is dystonia. That overflow of movement into an area of the body that doesn't need to be moving is what dystonia is. You also might notice when they're walking, particularly if they're walking fast, that their arm may pop up and posture. You might have heard that referred to as an associated reaction. Well, that too is dystonia. There's no reason for their arm to be coming up when they're walking. It's an unwanted movement. Now, particularly because the funding for SDR is different depending on your child's gross motor function classification, I'm just going to spend a little bit of time now talking about what that is, so that you can identify, if you don't already know, what level your child is. So the gross motor function classification score was developed because before we had this, we would just refer to children as having mild cerebral palsy or moderate or severe. And that's not very helpful because what I consider to be mild is not the same as what you may consider to be mild. So they developed this way of classifying cerebral palsy based on how a child moves. And there's 5 different levels, with GMFCS level 1 being children who have the most ability to move, and children who are at level 5 finding movement most difficult. Level 1 is children who walk without aids, they're able to climb stairs without the use of a rail. At level 2, they're still walking without aids, but walking is more difficult and they will need to have access to a rail in order to be able to do stairs. Children at level 3 use a mobility device, so they might use a walker or sticks or crutches, and that's in indoor settings. They may be able to climb stairs using a rail with some help, and they're likely to use a wheelchair when out and about in the community. Children at level 4 require assistance from someone else for their mobility. So they may have an attendant push them in a chair. They may have independent mobility in their chair if they have a powered chair, and they're just using, they have limited ability for walking, and that's more in a therapeutic setting. Children at level 5 use a wheelchair for all their mobility, and they have difficulty with head and trunk control. Now, together with the gross motor function classification score is the gross motor function measure. And this, unlike the classification score where you can read a descriptor and work out for yourself which level your child is, the gross motor function measure is an assessment that's done by a physiotherapist. And your child will be asked to do various tasks in lying, sitting, standing, walking, running and jumping if they can. And they will be scored as to how they can do all those different tasks. And those numbers can then be plotted into a computer and looked at against other children who have cerebral palsy. So when a baby is born, you get told what centile they are for their height and weight. So they might be quite skinny and on the 25th centile for their weight, or quite tall and on the 90th centile for their height. So the same is true for the gross motor function measure. We can plot your child's score against other children who move similarly to them who have cerebral palsy. So what you'll see in the slide is the typical motor curves for children at the different gross motor function classification score levels. So you can see the children at the top who are level 1, so they're children who can walk without aids and they can climb stairs without a rail. They will score the highest in the assessment. And you'll see that between the ages of 2 and about 8, all children are on an upward curve, they're gaining motor skills, they're able to do more year on year, and then they reach a point where their kind of maximum potential is achieved. And children who are walking without aids tend to maintain that level of motor skill into their adult life. But as you can see, for children who walk with aids, so children at level 3 and children who predominantly use wheelchairs at level 4 and 5, their level actually can decline after age 8. And that's because as the children get older and their body mass gets higher, they're putting on weight, they've got longer bones, it can be more difficult for them to move. So some of the skills that they might have had when they were younger and smaller and lighter can be lost as they go into their teenage years. And I think that's something that's quite difficult to hear if you're the parent of a child with cerebral palsy, and understandably so. So let's talk about treatments for spasticity in children who have cerebral palsy. Now, the NICE is the National Institute for Clinical Excellence, and they release guidelines for people like me and doctors and other people involved in spasticity management as to what the evidence for the best treatments are. And they released guidelines in 2012, which were updated in 2016, for spasticity management in children with cerebral palsy. So there are different treatments for spasticity, or the consequence of spasticity on the body. So some of these treatments aren't trying to treat spasticity, but they're treating what's happened to the body as a result of the spasticity being there. And which treatment we choose depends on where in the body the spasticity is, how widespread it is it just affecting 1 or 2 muscles, or is quite a large part of the body affected. So you might have heard the terms focal or global. So focal spasticity is just affecting a small part of the body. If it's more global, we're saying, well, you know, the hips are affected, the knees, the ankles, we're talking about bigger areas of the body. Our treatment choice will also depend on how much spasticity is affecting your child. So is it stopping them from being able to function, or is it causing them discomfort? Because how you treat something will depend on what your child's goals of therapy are. And that's true for spasticity as with other things. So lots of these spasticity management techniques you will recognise from your own experience with your child. So physiotherapy and of course occupational therapy. So your child may have done some specific task-focused therapy, they may have done muscle strengthening work, and they'll likely have a postural management programme, so use of specialist seating and standing equipment and walking equipment, and all of those things are trying to treat spasticity and the consequences of spasticity for your child. They may well have splints, orthotics for their ankles, or possibly also other areas. They may have undergone serial casting at their ankles to try and regain range of movement where it's been lost due to spasticity. They may have tried oral medication, so particularly oral baclofen, possibly diazepam. And those kind of first three areas are all pretty much bread and butter areas of spasticity management that hopefully you will all have had access to. If there are still difficulties with spasticity, then you may be referred on to a centre to look at whether botulinum toxin injections or Botox injections would be helpful to help manage spasticity. Now, Botox, you may know, is a short-lasting intervention, so the muscles that are affected with spasticity can be injected with the toxin, and this will have a period of paralysis for those muscles in order to try and gain range of movement or gain a skill that wasn't possible because of the spasticity. But over time the effects of that Botox do wear off, and you need to consider whether further injections would be helpful or not. Intrathecal baclofen, or ITB, is where a pump is surgically inserted into your child's tummy just below the skin, and then baclofen is pumped directly to the fluid around the spinal cord. This is a treatment for global spasticity, so where there's lots of spasticity around the body, and it's often considered most appropriate for children who are gross motor function classification 4 and 5. It can be a very effective treatment. I used to work in an intrathecal baclofen service, and I've seen firsthand how effective it can be for the right children, particularly for relieving pain associated with spasticity, and it can also be helpful for dystonia as well. Orthopaedic surgery may be required, so muscle lengthening or bony surgery, and this is to deal with the consequences of that spasticity. So where muscles have been in a shortened position for long periods of time, they may be permanently shortened and need lengthening in order for your child to be able to move in the way that they need to. So we have all of these treatment options in our toolkit, as well as SDR. And the NICE guidelines for SDR state you should consider selective dorsal rhizotomy to improve walking ability in children and young people with spasticity at GMFCS level 2 or 3. But they also stated at that time that further evidence was required about the efficacy, the effectiveness of SDR. So if you are talking to your local team about SDR, and if perhaps they might not be so familiar with it as a treatment option, you can feel free to direct them to the NICE guidelines, where it is stated as something that should be considered for children who are GMFCS level 2 and 3. So I talked a little bit there about muscle contractures, and I just want to go into that in a little bit more detail because it's something else that through conversations with parents I know can be difficult to understand. So when a muscle is in a shortened position for long periods of time, it can become difficult to stretch it out fully to its full range of movement. And this is really common in children with cerebral palsy. So often children with CP spend more time in sitting than they do in standing or walking. And so the muscles that are in a shortened position are at the front of the hip flexors, at the back of the knee, the hamstrings, and also around the ankle at the calves, because when you're sitting, those muscle groups are short. And there's less opportunity day to day for children with CP to be lengthening those muscles just through their daily activities. And spasticity also contributes to the development of contractures, because if you've got overactivity in certain muscles, and we said earlier that often it's one muscle around a joint more than the other that is affected by spasticity, so that muscle is going to be at risk of becoming shortened over time because of that overactivity. And it's really important when you're looking at treatments for spasticity to be able to differentiate between, is spasticity causing the movement pattern or the posture that you can see in your child, or is it a contracture? And possibly it's a little bit of both. But treatment to remove spasticity won't help with a contracture. So SDR might still be indicated, but you might also need an orthopaedic muscle lengthening procedure as well in order for your child to make the most gains with their movement. So I'm going to talk a little bit about the history of SDR in England, because it will help understand why some children are eligible for treatment on the NHS at the moment, whilst others aren't. So prior to 2014, there was only one centre in England offering SDR, and they had a very limited service, so there weren't many children undertaking SDR in the UK. And a number of parents were travelling to America from England to access SDR for their child. So in 2013, NHS England stated that SDR was not routinely commissioned due to a lack of evidence to support the procedure. So routine commissioning means that there is a funding pathway. So if your GP knows that you need a hip replacement, for example, there is funding on the NHS for you to go and have that procedure. So, and back in 2013, there just wasn't any routine funding for children to be able to access SDR. So in 2014, NHS England launched a commissioning through evaluation programme at 5 English hospitals to evaluate the outcomes of SDR and to investigate whether there was an improvement in gross motor function and quality of life after SDR at 6 months, and if that was maintained or improved at 12 and 24 months. So 137 children had their outcomes reviewed as part of that study, and in June 2018 it did become routinely available on the NHS for children, because it was found through that study that there was good enough evidence that children who fit those study criteria were having benefit from the surgery. So why might you choose to undergo SDR and intensive rehab for your child? So NHS England in that study found consistent evidence of improvement in patient outcomes from the pre-SDR at 2 years post-surgery. They found a reduction in spasticity, improved movement, improved gait or walking, and improved quality of life, including a reduction in pain for children, and the improved quality of life for their caregivers as well. They found that the procedure was safe, and there was also some anecdotal evidence of other things. So anecdotal evidence is where there isn't enough numbers of children to be able to say, statistically, we think this is something that will happen with the surgery, but there are enough children presenting with similar things to be able to say this is something that we're seeing. And the anecdotal evidence was of improvements in speech, arm function, improved bladder and bowel control, improvements in vision and cognition or understanding. The children were showing signs that they had better concentration, that they were calmer, and that they had improved body positivity. So one thing I wanted to talk about is around the need for orthotics after SDR, because I know that lots of parents struggle with orthotics. It can be really difficult to get your children to wear splints, to be able to get shoes to fit the splints, and I know that lots of parents have come to me at an SDR assessment and hoped that they will be able to forevermore be free of splints. So I'm sorry to say that for the majority of children, they are going to need and benefit from having splints following SDR. Prior to SDR, children are up on their toes, there's lots of spasticity in their calf, but following SDR, they've got that increased range of movement in their ankles, there's no longer spasticity in their calves, but they don't tend to have stable foot and ankle posture, and they do tend to need to continue with orthotics, at least for a few years following surgery. So I just wanted to include that today. Another thing, I asked a few parents whilst I was putting this presentation together, and some parents of children who'd had SDR also asked me to talk about what the outcomes might be, because I think they feel that on social media a lot of people share their stories of how their children have done following SDR, and it can be really hard to work out how your own child might do with this sea of success stories. And so I think one way of thinking about it is around what gross motor function classification score your child is. Children who are level 3 before SDR and who use a walking aid, in my experience, are unlikely to not require a walking aid at all following SDR. But a way of thinking around that can be, if you do your gross motor function measure assessment and you look at what centile your child is for a child at level 3, it might well be that they are quite good on their centiles, and there's a bit of overlap between them and children at GMFCS level 2. So for those children, they may well improve their walking significantly, so they no longer require a walking aid. But for children who are more borderline level 3 to level 4, it's unlikely that they will. And I think if reducing walking aid requirement is one of your goals, that's an important thing to look at prior to deciding whether SDR is right for your child. Another thing to think about is around the difference, if your child currently walks with a walker, the difference to them in their function if they're able to go from a walker to crutches or sticks. So as a teenager, being able to get into a car or a taxi with just sticks versus a large walker can be a huge difference in terms of how easy it is for them to get out and about. So they won't have changed their GMFCS level, they'll still be a 3, but in terms of improvement to their function, there will be a huge change for them. So it's important to think about, although their GMFCS level may not change, they can still have great benefits from SDR. So goals for SDR will vary for each child. And they will be discussed a lot during the assessment process for an SDR. And broadly, they'll be likely to be split between those children who have goals around improving their walking, if they're GMFCS level 2 and 3, or for improvement in care and comfort, if they're GMFCS level 4 or 5. So what is SDR? Well, it's a neurosurgery where some of the sensory nerves that contribute to spasticity in the legs are cut at the point where they enter the spinal cord. So it's not the nerves that allow movement, the motor nerves, which are cut. It's the nerves that bring the feedback from the muscles to the brain, the sensory nerves. Those are the ones which are cut. Now, SDR was first performed in the early 1900s, and the technique has been refined significantly over time. The procedure is performed under a general anaesthetic, and it takes about 4 hours. So there'll be a small skin incision made in your child's lower back, and that's so that they can access the very bottom of the spinal cord. So if you feel down your back, you can feel the bumps of your spine, and those bumps are the bones called lamina. So the surgeon will remove one of those bones in what's called a laminectomy, so that they can gain access to the ends of the spinal cord and cut open the sac that's around the cord. Here, the nerve roots are separated into the individual rootlets, and they're tested electrically to see if they're motor nerves, the nerves from the brain to the muscles, or sensory nerves, the nerves coming back. All the motor nerves are put to one side, and then the sensory nerves are tested to see if they are responsible for spasticity, and a proportion of those abnormal rootlets are then selectively cut. The normal and least effective rootlets are left intact, and also the nerves to the bladder and bowel are also left intact, so as not to interfere with bladder and bowel control. At the end of the procedure, the sac is closed again, and the skin is closed with absorbable stitches. The hospital stay is for about a week, plus 2 weeks of intensive rehab, staying in a local hotel. Physiotherapy. So it's been proven that evidence that NHS England used to decide that they would fund SDR for certain children, it wasn't just SDR that the children undertook, it was SDR plus 2 years of intensive rehab. So the evidence that SDR is successful is very important to understand that it's not just SDR, it's SDR together with rehab that can enable children to make gains in their movement skills. And the study we talk about 2 years because that was the length of the study for NHS England, but rehab really is for life. And you will transition over time with your child from doing very physiotherapy-led exercise and activity to finding sports and activities that your child can participate in that will help them maintain their gains and continue to exercise and be healthy, but in a more fun way. So it's definitely fair to say that SDR is a significant undertaking for your child and also your whole family, and so it won't suit all children. If your child currently finds it quite difficult to participate in therapy, perhaps they are also on the autistic spectrum, or they find it really difficult to follow instructions and to work with you or with their therapists, then you're going to need to think really carefully around how they're going to cope with the intensive therapy regime that's required following an SDR. The NHS England funding also includes money which can be used for community physiotherapy. So if you are accepted at one of the centres in England under a funded basis, then there will be some money that your local physio NHS team can apply for. Now, that is really fantastic, but it might be difficult for that individual team to be able to use that money because it will require there to be somebody with the capacity to do additional hours to be able to provide your rehab. So it's definitely worth talking early on in the process with your local team as to how that could work for your child. Unfortunately, that bolt-on money cannot be used for private therapy. And there are recommendations from NHS England as to the intensive frequency of rehab for children following SDR. So you can see here that for children, it's different for children based on their gross motor function classification score. So children at level 2, it's suggested will require less therapy than those at level 3. And you can see that it reduces over time, being more intense immediately post-op, and then tailing off in the second year of rehab. So let's go through the NHS England funding criteria for SDR. They must have a diagnosis of cerebral palsy and be GMFCS level 2 or 3. They'll be aged between 3 and 9, and that goes all the way up to the day before their 10th birthday. Spasticity must be mainly in the legs, affecting function and mobility, and there must be no dystonia. The MRI brain scan must show typical cerebral palsy changes, so white matter damage of prematurity or periventricular leukomalacia or PVL. There must be no damage to the basal ganglia or cerebellum, because you'll remember those are the key areas of the brain controlling posture and coordination, and damage in those areas is likely to result in dystonia or ataxia. There must be no evidence of genetic or neurological progressive illness. Sometimes children who present with typical movement difficulties of cerebral palsy don't have the damage on their brain MRI that we would expect, and they may go on to be diagnosed with something different. So it's really important that those children don't undergo an SDR. There must be only mild to moderate leg weakness with the ability to maintain anti-gravity postures. So one of the things that happens at an SDR assessment is a really detailed look at your child's underlying strength, because when you have an SDR and that spasticity is taken away, they need to have enough strength to be able to build upon. And there must be no significant scoliosis or hip dislocation. So children with cerebral palsy as a standard of care undergo regular hip x-ray, and you may already be familiar with what your child's Reimer's index is, and it should be less than 40%, so their hips need to be well and located. If there is an issue with hip migration or hip dislocation, it doesn't mean that they can't undergo SDR at a later date, it just means that that needs to be addressed first. So how can your child access SDR? Well, there are 6 centres in England that presently offer SDR via a single level approach, and they are Bristol Royal Hospital for Children, Alderhay, Great Ormond Street, the Portland in London, which is a private facility, Leeds and Nottingham. So another thing that the parents asked me to cover in this presentation was about how you choose where you go for an assessment. And I think convenience of location is a really key thing, because you're going to be going back and forth to your SDR centre for assessment and treatment and then follow-up for 2 years, as well as the inpatient stay. So being somewhere that it's not so difficult for you to travel to and from, I think, is a key consideration. You want to think about the experience of the team and what feels right for your family, and that may be very different from what feels right for another family. Happily, lots of people talk about their experiences of SDR in England on social media, and they all are overwhelmingly positive about the centre where they underwent their treatment. So it's really important that you think about what works for you and don't feel pressure based on what other people have chosen to do. Another thing you might want to think about is a requirement for orthopaedic surgery. So at Bristol, the orthopaedic surgeons are very much an integrated part of the SDR team, and so they're able to offer lengthening procedures if that's what's required, either during the same admission for SDR or at a later date, depending on your child's needs. So if contractures are a concern for your child, it's worth just talking to your SDR centre about how they can manage those. So let's look at a typical patient pathway for SDR. This is based on my experience at Bristol, but the pathways are quite similar for the centres in England. So firstly, your child will need to be referred for consideration for SDR, and this referral can come from your physio or your orthopaedic surgeon or your paediatrician or your GP and your local team. And they just need to include as much information as possible around your child's areas of strength and difficulty, past medical history in terms of what's been tried already for spasticity management, what your goals of therapy are, and to an extent, if they're known, how well they fit the funding criteria for NHS England. So once that referral is received, at Bristol you come to a spasticity clinic, and there you'll meet with a neurosurgeon and one of the physios to look at, does your child broadly fit the criteria for SDR? And if they do, then you'll be invited back for a full initial assessment. Following that assessment, there's a multidisciplinary team discussion, and this is with the neurosurgeon, the physios, the orthopaedic surgeon, our gait lab technicians and neurologist to look at what we think the most suitable treatment option would be for your child. And if that is SDR, then you will be invited to book your surgery with our SDR coordinator. When you come back for your pre-op assessment, it's an opportunity to just repeat all the assessment measures to make sure that all the changes that we then record in the future have occurred from the SDR and the rehab, and that there hadn't already been changes between your initial assessment and your surgery date. Then you'll be admitted for your surgery and your inpatient rehab phase. And then in Bristol, the children for the second 2 weeks of their rehab are put up in a hotel local to the hospital, and that cost is met by the hospital because they think it's really important that the child is able to sleep well, and wards are very busy places. So to be able to get the most out of your rehab, you'll stay in a hotel for those 2 weeks. Then you'll be discharged to your community team, coming back to your your surgical centre for reviews at 6 months, 12 months and 24 months. So thank you for listening. I appreciate it's been a long presentation. Hopefully it's helped answer your questions in terms of whether SDR might be beneficial to your child. If you want more information, there's a really good network of families of children who have either undergone SDR already or who other families like you who are considering SDR. They're on Facebook if you search for SDR UK. It's a private group, so you'll have to request to be admitted. And if you want any more information on SDR, including links to all the references in this presentation, please feel free to go to my website. Thank you.